All right, well, welcome everybody. Thank you for attending. I'm Greg Archer. I'm the Department Administrator at Ohio State, and I'll be presenting today with Kay Robbins. He is the Department Administrator at Penn State. Steve Maxwell is the Department Administrator at University of Michigan, and Alyssa Tyransky is the data analyst from Ohio State. So we will be presenting data on behalf of AAAEM. So we have been doing benchmark data collection since 2010. So today we're going to present fiscal year 24 results to everybody. So this is our disclosure. So the data we collect on many different type of operations. Today, the data we're presenting today will be on academic and academic affiliated emergency departments. So the end for that was 83 this year, and geographically kind of spread out throughout the whole country. So this data will be representing 5.3 million visits, 1.6 hospitalizations, and $750 million in collections. So every year we meet in the summer, the committee, and go through the survey and clarify any definitions we need to from the data we got in. And then we add a few questions, take a few questions out. So this year, the new questions we add were on occupancy data for mid-surge, boarding, got a little more specific on the data we're collecting for boarding, and CT throughput times we added. We also put back in patient sat, and then we'll explain to you why we did that. And then we also created an urgent care survey for the first time. So patient sat, we had collected this when we first started the survey. And then in 2014, we decided to stop because Press Ganey had benchmarks. We're like, why are we collecting this? We already have benchmark data. So for a couple of years, we quit collecting it. And I was discussing how bad our Press Ganey scores were percentile-wise with our vice chair of operations. And he said the same thing. He said, everybody he talks to in academia says, oh, we're the 15th percentile. No one ever says, we're the 50th, we're the 60th, right? Everybody's scores were low. So then we said, well, maybe the benchmark's not really right. So we decided to start collecting again for AAAEM and made our own benchmarks based off of everyone's data from AAAEM. So what we're showing you here is longitudinally what the OSU's data look like. So we're the little blue line. You can see the data was pretty consistent. So for this past year, for AAAEM, the mean score was 74.8, median 79.9. But what we did was when we took all the AAAEM data and made our own benchmarks, we compared that to Press Ganey. So the lines you're seeing, the green line is Press Ganey's large hospitals benchmarks. The red is what they consider academic. And then the blue was the AAAEM. So this just happens to be FY18, but we did this for multiple years, and it came out to be the same. Basically, the Press Ganey benchmarks, the two benchmarks for large and academic, were statistically not different. It's basically the same benchmark. But the AAAEM data was statistically different. So, for example, in FY18, if you had a score of 82.5, Press Ganey, you would be the 17th or 23rd percentile. But if you look to the AAAEM benchmark, you were the 65th percentile. So much different story, right, to the C-suite. So the chairs saw this and they all like, yeah, you guys need to keep collecting this. At OSU, we showed this to C-suite, and we're actually, when we use this for the faculty's incentive, we're allowed to use AAAEM, we don't use Press Ganey. So we're collecting that again. And for this past year, 25th percentile, Press Ganey score is 82.78. And for our database, that would put you at the 87th percentile. So again, bottom line to this is whenever you're doing benchmarking, obviously the basic thing is make sure you get the right cohort group. Not just because you look better, but it makes sense to compare to the right group. Urgent care wise, first year we did it, we got 14 responses. So we're going to see if we can get more next year because a lot more institutions seem to be getting into urgent care. About 20,000 patients. Interestingly, which you would expect versus an ED, have more unique patients, not as many repeat visits. Don't see as many patients 65 and older, and the payer mix is different because strategically, usually urgent care is placed in different places. And most of the patients there are obviously disposed, treat released. All right, so now we'll get into the some teaching data. So obviously, what they came out with potentially moving everybody to 4-year programs. We've been collecting this data for years, and it's pretty consistent. 72% of the programs that report data to us have 3-year programs and about 13 residents per year. So then we're interested in seeing, well, where are these 4-year programs located versus 3-year? So you can see the Northeast has the highest number of four-year programs, and the South, in our database, have no four-year programs. All right, move on to some clinical data. One thing we heard a lot of was, well, hospitals aren't staffing all their licensed beds. Like, we have a lot of beds that aren't being utilized. Turns out last year, 92% of the licensed beds were being staffed. As far as the data, total visits, 65,000 was kind of the average, with 16,000 admissions. And if we look at that again, since 2019, you can see the total visit number was 64, and then COVID hit, so it dropped. And now it started to bounce back to whereas this year, we were actually higher than we were back in 2019 for total visits. Interestingly enough, treat and release did the same thing. They dipped when COVID hit, but they have not quite rebounded back to previous COVID numbers. But admissions stayed pretty consistent throughout COVID and have actually even started to go up. Patient population number's been pretty consistent for these different cohorts, except for patients greater than 65. Back in 19, this was under 21%, and this past year we bumped over 23%. So it's going to be interesting to see if that trend continues. Take care of the older population. As far as physician coverage in the department, in the acute care space, about a third of the hours are attending. A little over half are resident hours, and then the rest are APP hours. So if you look at the total ED coverage, that would be front end, OBS, triage, wherever else you might have providers working. Still about a third of those are attending hours. Now the resident hours come down and the APP hours go up. As far as charging and productivity goes, worked hour reviews per hour per patient, pretty consistent. Collection per hour reviews, pretty consistent. Big thing that changed here, if you look, we went from 7.7 million to 8.4 to stayed at 8.4, and then this past year we went up to 10.4 million. So that jumped out at us. We're like, why did that happen? So we looked at it and we looked at who submitted data in 23 versus who submitted data in 24. So the new ones in 24 that submitted data, their collection rate was above that number, but above 10,000, so or 10 million. So it pulled that number up. The ones that reported in 23 and dropped out were below that number. So, they worked in the opposite ways to make the number go up. So then we said, well, let's just look at who reported data in 23 and in 24 to make sure this number is really increasing. I mean, if you just pull the institutions that reported in 23 and in 24, that number is 9.5 million. So it is going up. And then if we also look at collection per visit, that is also going up. So it kind of goes hand in hand with our number of admissions as a percentage of our total visits are going up, elderly patients, and obviously then the acuity is going up. Makes sense, we're collecting more. As far as payer mix distribution, this was a little interesting. We're going to keep an eye on it because Medicaid took a big dip and commercial went up. So that would go, again, along with collecting more. But 1 year might be a blip, so we're going to keep our eye on this one. And then the codes, ENM codes. So when the new guidelines went in 23, they said 1s and 2s should pretty much go away, and they have. 3s have actually dropped, and 4s and 5s in critical care are going up. So that change was obviously good for us. Plus, again, we're seeing higher acuity patients. So it's showing here. So again, going back to look at the trend, the volume trend. So now we're going way back to 14. So as you can see, 14, 15, 16, 17, we're trending up in all these three different metrics. And then for some reason, we started to go down in 18 and 19 for total visits. And then obviously COVID hit and we bottomed out in 21. So again, total visits are kind of coming back to where they were. They're not quite where they were in 17, but they are higher than we were in 19. But if you look at treat and release, the red line, it took a dive again during COVID, and we haven't really bounced back for treat and release patients. But if you look at the admission line, very flat, and then this past year it actually bumped up. So we looked a little deeper at this, and interestingly enough, just showing treat release, the red line, and then admissions, the green line. Look back to 14, for every admitted patient, we took care of 3 treated and released patients. But now that ratio's down 2 to 1. So again, we're seeing higher acuity of patients. And go along with that, hospital admissions are going up, and 58% of those are coming, again, through the ED, which correlates to what we've been reporting. Same with EMS traffic. 44% of them are coming through us, and that number's also going up. So from there, hand it over to Kane.
Yep. So Kane Robbins, Penn State University. So I'm going to go through, take this to the kind of next level, look at some of the factors, the timings, the activities that are impacting the units. We're going to talk about boarding. I'm sure people are sick of it, but it's some interesting stuff in there. And we'll look at ancillary services and some other things as we go through this. So the first thing that I'm showing here is the impact of the inpatient unit. So we do collect census data from each of the hospital to look at, obviously we know that's part of the boarding story. And so what we do, typically you do a midnight census number, and that's what we're collecting here. But we also took it a step further and said, can we collect the 7 a.m. census number? Because we know what happens overnight when our volumes kind of start that next day, what's going to be happening. And as you can see here, that 7 a.m., the census in those inpatient units is even higher. So we know on an average regular day, we're already starting behind the 8 ball. There's not going to be space for our patients coming in, hence boarding numbers increase. Another factor or an offshoot of that, and kind of at the end of the story though, is our unfinished care. So this is just information to see. You can see about 8% of our patients are not completing their care. So about 1 in 12 patients coming in isn't getting finished up. And so that number over the last couple of years has been increasing. But we know that's an offshoot of all the other things that we're kind of seeing happening in the department. As we talked about some of those numbers going up for the number of admissions, but we're also seeing a spike over the last couple of years in those lengths of stay. So we're really seeing a huge impact over the last 3 years. It did kind of go down a little bit this year, but we're going to call that flat because it's not statistically a real change. So you can see that red line up there. That's really kind of admitted numbers taking a huge step. So if you worked in the emergency department 10 years ago, it probably felt, obviously it felt much different than what we're seeing now because that number has changed greatly. But you can also see our discharge numbers, discharge patient numbers are also going up almost an hour more than where they were 10 years ago this time. So all those pieces are getting longer. This is more just interesting to me. This is kind of the mean and median total length of stay. And, not a huge fluctuation in there, but you can see we're consistently at that gap of outlier patients, about 2.5, which is kind of just interesting if that outlier spread kind of stays pretty consistent. But when you look at the discharge patients, this is where it's kind of changed the story a little bit. That delta is actually shrinking. So that means a larger portion of our discharge patients are feeling those longer lengths of stay. We already kind of looked at the hospital patient length of stay, kind of a little bit of a dip, but it's not really coming. It's not like we should celebrate this because there's a lot of other factors hitting that number. And when we look at our bedded decisions, pretty consistent over the years, up and down a little bit, but that decision time, the processing time for the providers, not a ton of change in those numbers year to year. So that's good that we know we're pretty consistent in that area. Here we go. So we'll start the boarding time conversation. These are the boarding hours, and you can see that 4 hours for those medians. Again, fairly consistent over the last couple of years, but obviously a lot of outliers. There's a ton of that gap is pretty big. So we have a ton of long stay boarding patients in those figures. But when we go back to the slide Greg showed, when that ratio for admitted patients has changed, that flatness of the boarding hours really isn't flat. Because what's happening is as we've increased the number of patients, and even though our boarding times per patient maybe went down a little bit, that the total boarding hours is increasing because our patients are getting sicker. We have a higher acuity patient population. So our boarding, you can see, has gone from, filling about 9 beds a day to almost 17 beds a day are being taken by boarding patients. So a big impact there. We looked at the distribution of the patient population, and again, we would think this maybe looks pretty good. Like the number less than 4 hours has gone up, which is good information, and the percent greater than 8 hours went down. So just looking at that, you would think, oh, okay, there's some improvement. But again, when we take the raw numbers of patients, that decrease on the 8 hours is really a flat number when you look at total hours. So be cognizant of that, but some good news in there. Another way to kind of look at it, we took, again, those percent of patients greater than 24 hours. And so the blue line represents 24 compared to the red in 23. And you can see it's on the curve kind of moved to the left. Yeah, left, which is positive, right? So we're seeing that. This is all the institutions. So that's a positive curve. But again, the same conversation comes back when you look at total hours. It actually goes to the right because when you factor in the higher volume numbers. So in here, just trying to look at our subcycle times, what's happening in that. Really, the arrival to providers where we're seeing an impact. The patients aren't getting back to the providers quicker. It's going down, and so or it's increasing. So that's where we're seeing most of the increase in the patient study. The last couple things are a switch off of that wording and that kind of timing. So ancillary, you can see that ancillary services, we're using more CT, we know that. But that's because our patient population is getting sicker. We're seeing more admitted patients, that's showing in the data, but the times are also getting longer. So again, impacting the patient population. Same with MRIs, increase with huge cycle times on those up to 10 hours. So long times there. Behavioral health patients, again, sort of, when you look at our discharge patients, somewhat flat, but the percent of patients that are behavioral health are increasing. So about 6% of the population. So it's impacting our overall numbers. And my last piece is observation. Not a ton of change there as far as volumes. The lengths of stay had been increasing, went down this past year, but still, so we'll watch that. But that kind of continual growth is kind of slowed a little bit.
Hey everybody, Steve Maxwell from the University of Michigan. I'm going to walk us through some of the data around the research that we collected. And one of the things that we talked about was there was about 80 to 90 surveys completed a year. And there's about 120 institutions that are part of SAEM. So 75% roughly in any given year submit data. What you'll notice here is about half of the institutions that submit data submit research data. And what we believe that means is the externally funded research, particularly from the NIH, is centered in a smaller number of institutions. And what you'll start to see as we look at the data is the impact of research on the specialty as a whole is centered probably in 10 to 12 sites across the country. And so what you can see here is that our number of submissions over time has crept up, and that our conversion rate, the rate at which we receive funding relative to submissions, has actually gone slightly down, but has stayed in that 40% range. What we've actually noticed is that the conversion rate is the same whether you're from an institution that does $25 million a year of research or does a very small amount of research. It's about the same whether you're an assistant professor, an associate professor, or a full professor. So those that are the best funded senior professors, they don't get more grants their conversion rate is the same. What they're doing is submitting more grants. So the more that you submit, the more that you get. And we'll talk a little bit about that as we go through the other slides. NIH funding for this year was $107 million for the specialty. Our survey represents about 77% of our survey was 107 million, NIH was 137. So we are about 80% of the overall amount of funding from the NIH. And when you look at Blue Ridge, we are 78% of that. So I think we're consistent. This is a graph showing the funding by institution. And we've really never had a single institution above the $30 million range. There's one large grant that came in this year for one institution. that push that number up to 40 million. We've typically seen between 5 and 8 institutions above $5 million a year of direct spending. What you can see is that the overall number of institutions with more than $5 million a year in spending is increasing, and the overall rate of spending at those institutions is increasing. And what this grant sort of shows you is the grants submitted relative to total spending. And what you can see is that there's a correlation. The more you spend, the more you submit. And so a takeaway from this is spend your time submitting and your conversion rate will be consistent with everyone else, assuming that's consistent with the data, and your overall research, investment, and spending will go up. So about 5 years ago, SAEM leadership set some goals. And what you can see up here is the 2030 goal from 2020, a 10-year goal of $100 million in NIH funding, 200 NIH grants, 150 funded PIs, and 50 departments that have funded effort. And what you can see when you look back at when we were doing that is that was an aspirational goal. But what's actually happened is that our number of PIs is above, our amount of funding is significantly above, and we're approaching in the number of departments. So the amount of research done across the specialty in the last 5 years has materially grown, and it's grown at a faster rate than we predicted it would 5 years ago. And so the story here is that submissions are increasing, funding is increasing, and the number of PIs are increasing, which is all great news until you look at the current political environment that we're in. And so we decided to do a little calculation to say, if F&A were to decrease to 15% as is proposed, what would that mean for the specialty of emergency medicine, knowing that it is disproportionately borne by a small number of our institutions. And what you can see is our directs are $93 million a year, our indirects would be $29 million a year, or an average 30.8 IDC rate. We would apply our survey's results to the 159 million of total NIH funding. So if that 30.8 were reduced to the 15, that would be an effective reduction of revenue to the specialty of about $20 million a year. Now, we do know that 9 departments have more than $5 million a year, so a disproportionate amount of that decrease would be borne by those 9 departments. And that was really what we came up with for a summary of our research data this year.
Thank you. Hi, I'm Alyssa Tyransky from The Ohio State University, and I'm also the data manager for all this fun data. So I'm having a plug at this moment. If you think this data is super cool and you want to learn more about it or even publish it, please reach out to me. We love to expand our knowledge. And now I'm here for the main event, why you guys are all here, salary data. First off, PAs and NPs, we're talking about APPs. Their salary data is pretty consistent year over year. Same with the amount of PAs, NPs we have in our departments, male, female, that ratio is pretty much the same. Most of our APPs are in more than one location in our department. And here's a nice little graph showing their salary trend. One thing we also want to point out is salary and hours worked by region. So if you look at the salary column and you look at the total hours worked column, there's definitely a disconnect when you look at those columns by themselves. So we this year wanted to look at their hourly rate. And as a specialty, we are within like a $10 range of each other. So regardless of where you are in the United States, there's a pretty consistent average base hourly rate for our APPs. And now the salary for our attendings. I want to point out, so for FY24, we had a little dip in participation from 2,600 to 2,300. And I want to point that out specifically because we may see some participation bias in some of the results that we see. Otherwise, years in EM, post-residency, things like that, consistent year over year. Our EM faculty, again, very consistent in terms of how long they've been in the specialty, including at rank. So again, we're seeing a consistent amount of instructors, assistant professors, and again, their years in EM, very consistent with what we've been seeing year over year. Clinical hours and site work. So 1440 is that magic number we see pretty much every year of if you are a 1.0 FTE and your vacation has been accounted for and you have 0 buy down, this is what we expect you to work, 1440. In terms of minimum clinical hours, 384 seems to be the consistent number, so about 4 shifts a month. About half of us recognize sign out, and majority of us assume a 40-hour work week. The hours worked base versus total hours is pretty consistent across the board as well. Overall, about 900, and then there's about 80 hours of overtime worked, and that decreases as you go up in rank, both your base and your hours worked. And then across the board at your various sites, so academic and academic affiliated, so presidents of a residency, those are lower, and then community and freestanding have higher bases for the hours worked. Salary. So although it looks like going down, we are not interpreting it as you guys are making less money. It is more of the participation bias I was talking about earlier. But the percent base is consistent throughout the years that we've had. This does not include chairs and it does not include peds, i.e. groups that would definitely skew the data. So this is just your run-of-the-mill emergency medicine, assistant, associate, and professor and instructors. By rank, so again, slight, if you look at the microscope, instructors and assistant professors have gone up a little bit. Associate and professors have gone down, and when we looked at it a little bit more, it was in the the incentive and bonus piece of the puzzle. Again, we're not like looking as like, oh no, us as a specialty, things are going horribly. This is just more of a slight little trend. Our first year faculty, they have actually had a 5.5% increase in their total salary. A lot of that is attributed to working shift diff, like those late night hours, a lot of the overtime. Salary trend by region. So there's about a 12.5% discrepancy between our friends in the West and our friends in the South. Nocturnists, we want to call it a couple of special groups. They're about 14% of our workforce. And when you think of nocturnists, think of more. They work more hours. They make more money. They work more overtime. All the things, just think more than your non-nocturnist faculty. And we also wanted to look at our friends in the community sites that are part of our database. Our base compensation is about the same as well as our total salary. There tends to be more overtime opportunity or more less protected salaries, some may call it, that gets worked at the community sites, but overall, pretty consistent. And then faculty benchmarks. So overall, there's about 30,000 physician hours that are worked at our sites. Patients per hour is about 2.5 patients per hour. Staffed in terms of billed, about 1.2 or 1.1. RVUs per CFTE, about 10,000. And work RVUs per MD hour, 6.7. Thank you so much, and we will take questions.